Oh, great. We have a question over here. Don't be shy.
Can I just yell?
Yeah. No, that's good. Go, use a microphone.
So, when you were talking about the headache specialist that you would refer to if they're not a surgical patient.
Correct.
So we were referred to a headache specialist, but they turned the referral down. Would you just try first someone else? Why would they
turn it down? Well, let me give you an overview of that. So my guess, the reason they quote unquote turned it down was because they saw you at a Chiari, or the person had a Chiari, and
No, he doesn't.
so there's no Chiari, but just a straight headache. Yeah, I mean, that's part of the problem. That's why I brought that to light, that seeing a headache specialist is difficult. So the people that are fellowship trained in headache and a lot of these centers, they kind of pick and choose what they want to do. And, you know, the run-of-the-mill headache in their mind is, well, your primary care doctor can take care of that. What they're interested in are these really complex headaches where they need to get ketamine infusions and do all this other stuff. In my opinion, I think it's a really broken system. I'll be honest with you. I'll see headaches. That's one of the reasons I got a pharmacist, was to help me with that. Because a lot of our patients in the neurosurgical realm see headache patients, and you know, a lot of the primaries are inundated because they're getting this. The pediatric population is even more confusing because they're so multifactorial. It's a problem. It's a real issue. So what I would say is, you basically you need to keep turning stones, is the bottom line. But for headaches, you know, you need to find the right person. I guess I would say start with the primary care, because the headache centers are, it's a double-edged sword.
I mean, it was with the Oregon Health and Sciences Institute,
Yeah.
who we saw, and
Yeah.
so it was a colleague of his who we happened to see her in something that she was this leading headache specialist, and blah, 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 after she turned us down. I was like,
Yeah, I can talk to you offline. We can, I'm happy to, but yeah, it's not uncommon, unfortunately, what you're saying. So one of the things that we want to do too, so and especially as we go on in some of the more specific talks, one of the things that we want to talk about is things for, we don't want to use names of doctors. We don't want to, you know, I'm sure there's some people in the room that have issues, so we'll keep all that stuff offline, and like what you're saying, like general discussions of issues. If there's specific questions, that's why I said this is nice. You got us trapped here for 3 days. Pull people aside, ask them. You can ask personal things. But got a question over here.
So I guess my question is, when you have a person who has a very complex history, there's a lot more going on. I mean, you're talking Chiari Syringomyelia, EDS, a very vascular invagination, a whole myriad of issues. What is being done in the medical community itself to educate other physicians that can be more, I mean, because there are even neurosurgeons who are not educated and don't really, and people have gotten stuck and have gotten in bad situations because of that. So what is being done to educate even other neurosurgeons about these types of patients?
It's a great question, you know, and again, we'll open up this is anybody can chime in, including the audience. I mean, we need to do a better job. That's why organizations like ASAP are so important. I think your point of other neurosurgeons, a lot of neurosurgeons, particularly general neurosurgeons, want to do Chiari's. Oh, it's Chiari surgery. It's great. I did a bunch of these, and it's okay when it's the run of the mill. But when you start getting into these more complex things, it does then become an issue. So I think, you know, clearly, I would say it for a lot of things in healthcare. We need to do a better job of communication amongst ourselves, amongst healthcare providers of communication, but also kind of why I was hammering home about the education of the patient. And it's not just a surgery. You got to look at the whole picture. So what, you know, any disease process where it's not a huge population, it tends to be, there's benefits and drawbacks. And the drawbacks are, a lot of people are just kind of like, well, Chiari, yeah, it's a small population. It's not this, it's not that. We have to do a better job. And I would challenge and ask everybody in this room to help with that. But things like ASAP are a great organization for that, but we do need to do a better job. It's a good point. So a couple hands back here.
Hello. I think I remember you saying earlier for patients with Syringomyelia and who are not asymptomatic, so having a lot of symptoms, that you would recommend surgery. I was diagnosed at the beginning of this year and not recommended surgery. So what do you think that would be on a basis that my physician perhaps didn't have the education of a treatment?
No, I mean, I think, as I said, the main thing is every patient specific. So Syrinx alone without a Chiari, those are the ones that I said we usually don't operate on. And they're symptomatic, but they're a problem. A symptomatic Chiari with a Syrinx, if you have a Chiari and a Syrinx and you're symptomatic, that almost always we will recommend surgery. But there's always, again, and I'm happy, us or myself or any of the other surgeons are happy to talk to you offline about you specifically.
Sure.
Yep.
Thank you.
Behind, actually,
Okay, Chiari brings with it its own form of, I would say, specialized form of headaches. How is that related to migraine?
So they're different entities. Migraine is a very separate entity than a headache that's caused by Chiari. So Chiari headache and migraine headache are two totally different entities. And for the most part, I would say almost exclusively, a classic migraine, even in the worst of Chiaris, it's not going to treat the migraine. And I will give you an example of patients that have, multi-faceted symptoms that are weakness, motor, walking, and headaches. And they also have migraines. They're two different types of headaches, and it's pretty distinct. After the surgery, that Chiari headache, what they'll say, is completely gone. They'll be like, that headache I had before, that pressure feeling, that radiation, that back, that's gone. But you know what? I'm still getting headaches. And you decipher them out, and that's the headache with the classic photophobia, loud noises. So they're it's a different subset. And that's why it's important to dissect those out. I think there's another couple more here.
Hi. First, I am 4 weeks post-op. I just want to say that.
Oh,
to your
good.
question. So I'm feeling great.
Good.
No Chiari headaches.
Great.
My question, I guess, is I have 2 young children, and just how much evidence is there regarding genetics or how hereditary this condition is?
That is a great question. And I'm going to leave that to my pediatric colleagues. Well, and I don't know, I see Grant back there. I see actually most of the faculty here are in the pediatric population. But there's a lot of research going on into that. Currently, we don't screen children of things like aneurysms or other syndromes that we do. But Chiari in general, we don't. But there are some linkages, and Grant, you have any?
Yeah, I mean, it's a tough call. I mean, as you know, as was said, that it's way more common than we probably know because we don't MRI everybody, right? That's part of the issue with genetics, is that we're not screening everybody, but that's the general rule. Unless someone's symptomatic, we don't put them through that. However, if there's part of some other syndrome or some of these associated conditions, which I think Dr. George will highlight later, those ones we might screen because there's a higher link for the genetics that might come up, like Klippel-Feil, things like that show up. But in general, it's really rare. It's definitely lower than 2%, we think.
Okay. That's good.
Yeah, it's a really good question.
Yeah. Thank you. And I have mentioned to my pediatrician too, just so they're
Yeah.
aware.
Yeah, but I mean, in general, I would not worry about it.
Yeah.
You took the hit for the family, and now you're doing great.
Hopefully,
so.
right? Thank you.
Yeah. We have a question up here.
Thank you. 2 questions. One, what is is there a correlation for risk of developing Syrinx after the initial discovery of a Chiari? And they just, if you can see that there's a buildup of pressure or a flow limitation?
And again, we're going to have a great talk just on Syrinx, and I think let's bring that back up during that discussion. But in general, the more of that, because even in the worst cases, you saw those cine flows where that fluid's pulsing, and we can. It's a very a dynamic process. It's not static, meaning that when there's that real, we typically see in like that one picture that Dr. Hidayat showed where you don't even see spinal cord, you just see Syrinx. There's just complete blockage there. There's nowhere for that flow to go. So there's that pressure buildup. So if you could walk around with an MRI and see when you're lying, when you're sitting, the patients that tend to develop the Syrinx are where there's just a chronic blockage there, where there's just no CSF seeping through at all. Mm-hmm. But I think some of our speakers are going to get into detail about that.
And the second question I have is, in young children, what's the rate in which children can outgrow this? Do you see?
That's a great question.
'Cause-
That is a great question, and again, I'll open that up to my pediatric colleagues. I don't think it's a small. I think it's again, given that they're asymptomatic. But did you want to answer? Yeah, you. Dr. Yeah, no, you got the mic.
Well, we did it's a really interesting question. We did a study on when I was at Duke, but it was basically between the ages of 3 and 6 or so. There's a lot of changes going on, and particularly in the kid that was asymptomatic. That's key. Picked up incidentally for other reasons, like the kid had a seizure and had an MRI showing a Chiari, but no symptoms that we could say that, okay, this is something that we're just going to watch. Between 3 and 6, the bone outgrew the brain, and the Chiari reversed a lot of the time. And we did all these morphologic measurements of volume and showed that change was happening. But after 6, things get more fixed, and it's hard to see a lot of reversal. And it's a great question of, why do we see these discrete ages of presentation with Chiari? There's about the 6-year-old, there's this 12 to 15, there's young 30-year-olds. Why is that? We don't have a handle on that. But growth definitely, I think, plays a role in these kids. You have any comment about age?
Bob Keating did a natural history study, which he will probably present. I don't know what he's talking about, but he probably will say something about this when he comes today. All I would say is that, in general, our experience has been that the ones who start out symptomatic, it's unusual for the symptoms to go away, and they often will progress. The ones that are not symptomatic, especially beyond 5 or 6, oftentimes don't really, it's a small portion that becomes symptomatic later. And this is one of the reasons that we don't screen, because you're not going to operate on an asymptomatic patients. The rate of syringomyelia is low. So I agree with Jerry that 3 to 6 seems to be the right age to see that switch. So.
And interestingly, in the adult population, you'll see an outgrowing as well. As we get older, the brain shrinks and atrophies, especially when you start getting to the 40, 50 population and on. But in the adult population, you will see some patients that have mild symptoms, and then they kind of go away. And you see that in the patients who just absolutely don't want surgery, even if you recommend it. But I agree, it's the same thing. Once you become symptomatic, it's either static or worsening.
I didn't think about this the first time, but it's becoming clear that apparently mine is attributed more so to trauma. But since I hadn't had images prior to and anything to compare, my mother has Chiari. And so is it possible that maybe I had a Syrinx present and a traumatic injury can emphasize those
Or exacerbate
symptoms?
it?
Yeah.
Yeah, I mean, that's a huge question, especially in the medical legal world.
I know,
of
it's like one
the
case.
chicken and the egg of the Chiari. No, there's actually, I mean, and I'm open to everybody in the faculty. My personal thought on that is the patients that have traumas, they've had a Chiari and they just didn't know it. And whether this and sometimes that will clearly bring on a Syrinx, even if you have a Chiari without a Syrinx. If you're involved in a serious trauma, particularly with like a craniocervical, like a whiplash type thing, or which it
I
sounds
was
like.
snow skiing and I hit a tree.
Yeah, those types of injuries, if the Chiari's there, but there's just, as Dr. Hedayat showed, there's no room there. There's no cushion, there's no, so you're kind of fixed, and then there's this stretch. So, yeah, and that may be coming into some of the issues where, in general, a lot of people will walk away, not walk away, but, you know, the outcomes aren't great with traumatic syrinxes with surgery.
Got it.
Let's do one more question back here, and then, again, no one's going anywhere, so we're gonna, you know, and I love the interaction.
Yeah, just a comment, Roger Kula. Under those circumstances, sometimes it's helpful to look for connective tissue disorders because many of those patients are susceptible to injury. If you have connective tissue laxity, you're going to be more susceptible to injury. So that's sometimes a reason to look at for underlying connective tissue problems.
Yeah, it's a great point. A great point. And there is not a small percentage of that you do see. So what we'll do now is let's take, and let's try to keep it so that we can kind of stay on track, like 10, 15 minute stretch your legs, coffee break, and then we'll come back for the second session.